The Family Foundation has put together a very nice summary of the Affordable Care Act, and they last updated that during 2013, so it includes all of the changes that were a result of the Supreme Court decision in 2012. That is available for you to look at, and in more detail, it is listed in, I think the section is called Additional Readings on the Moodle website, and so you can find that summary there. Now, the focus of the Affordable Care Act was on access to insurance. So we'll review the major provisions that expanded this access to insurance. It does not have an emphasis on making a more efficient healthcare system or cost control. That's kind of step two. The first step is the Affordable Care Act making care affordable to individuals. The major provisions are the individual mandate, the employer mandate, the expansion of Medicaid, and the subsidies for the low-income individuals. Those are the big four that you hear about the most. Then there's a small business tax credit. We'll summarize some other tax implications that happened through the ACA. We'll talk about the establishment of the health insurance exchanges. That HIX is an abbreviation I use for health insurance exchange. We'll talk about the essential benefits package. We'll talk about minimum loss ratios and extending dependent coverage. Let's talk about the individual mandate first. Each of us is required to purchase health insurance coverage or take advantage of health insurance that's available to us through our employers, or take advantage of Medicaid if we're eligible. We need to get ourselves covered. And at year end, when we do our income tax filing, there is a check. It asks, do you have insurance? And you do get proof of that insurance coverage from your insurer. If you cannot prove that you have health insurance, you're going to be penalized. That penalty is fairly modest at the beginning of the individual mandate in 2014. I think it was about $65, and that's not much compared to the cost of getting coverage over the course of the year. But that penalty will eventually be fully phased in at 2.5% of household income. So that's going to be a pretty stiff fine. Take 2.5% times a $50,000 annual income, and you're getting some real dollars. Now, if the lowest cost option available to you, perhaps through employer-based coverage, is more than 8% of your income, and your household income is low enough that you're not required to file federal income tax, then you're exempt from the individual mandate. Although if you had federal income that low, you probably would be eligible for Medicaid if you were in one of the states that had a Medicaid expansion. And we talked about this in class, that individual mandate is an important component of the Affordable Care Act, and it's what holds the thing together, because without the individual mandate forcing the healthy individuals into the risk pool, the elimination of underwriting requirements and reforming underwriting would not have been possible, because insurers would not be protected from adverse selection. So this is a critical piece of making the whole thing work together. And so it was with great relief that the authors of the Affordable Care Act heard that the Supreme Court upheld that individual mandate in their 2012 decision. The employer mandate was put in there. It's primarily a financing tool, because historically employers have been providing a lot of the insurance for the under 65s in our country. And there was concern that if the Affordable Care Act was put in place, employers who had been spending money on these benefits would suddenly drop coverage, and that would cause a lot of disruption in the system. And so the employer mandate was put in there to require employers that had more than 50 full-time employees to continue to offer insurance. If they did not offer insurance, then they were subject to a penalty as well. It's the lesser of two amounts, $2,000 times the number of full-time employees in excess of 30. So if you had 60 full-time employees, that difference would be 30 times 2,000 would give you a $60,000 penalty. The other possible penalty would be $3,000 a year times the number of full-time employees who are getting a premium subsidy through the health insurance exchanges. So if your employees you paid a low enough wage that even though they worked for you full-time, their income was below the limits. And actually, that limit is not terribly low because the premium subsidies go all the way up to 400% of the federal poverty limit. So that penalty would be $3,000 for every one of your employees that was getting a premium subsidy in the health insurance exchange. The employees actually ultimately pay for these benefits through reduced wages, right? Because your total compensation is, if the price of your labor is equal to the marginal productivity of the employee, then that balance has to hold whether that compensation is paid through benefits or through wages. So if we require an employer to pay benefits, then there will be reduced wages. Conversely, if we don't have the employer mandate and employers drop health coverage, we would expect to see wages rise over time. Now, I said that this was put in there because it's a financing tool and it was there to avoid a lot of disruption, but it's not really necessary to make the rest of the law work in the same way that individual mandate is necessary to protect the insurers in the face of the underwriting reforms. Because the access issues were solved by the health insurance exchange, we don't need employment-based coverage to give individuals access to insurance. And there is kind of a subtle acknowledgement of this. It's been repeatedly postponed. In the long term, because this act had to be budget neutral, in other words, when the cost of the subsidies and the other parts of the plan were paid for through additional taxes and penalties. So if we eliminate the employer mandate, those penalties that were going to go in place, that revenue's got to be found somewhere else. But that's the only real reason to continue to maintain the employer mandate. I wouldn't be surprised if we see that negotiated away over the course of the next couple of years. The Medicaid expansion was also a big piece of this, and you can see down there that map that we've seen in other forms before. Here in this version of it, the green states are the ones that expanded Medicaid, the yellow are the ones that chose not to expand to Medicaid, and the blue are the ones who got coverage to that segment of their population through an alternate means, perhaps buying coverage for them on the health insurance exchanges. So previously, we talked about Medicaid, and Medicaid had coverage up to, well, in some cases, I guess we didn't talk about the minimums required by the feds. We only looked at the requirements currently in Minnesota. So we didn't talk about this in great detail, but I'll tell you, for example, in Texas, there are some categories of people who are eligible for Medicaid only until they hit 25% of the federal poverty limit. So there are some big gaps in some states, particularly for adults without kids, in terms of eligibility for coverage. And so this Medicaid expansion was supposed to fill in for that very, very low income group. All people who are not already eligible for Medicare, so they're not 65 yet, and they have an income under 33% of the federal poverty limit, they should be eligible for Medicaid under this new expansion to childless adults. The first 3 years of that expansion, it was paid completely by the feds, and then over the next 4 years after that, it was going to phase out to being paid 90% by the federal government, 10% by the state, and from then on, the federal government was going to pay that 90%. The Supreme Court's 2012 decision that upheld the individual mandate actually undermined the Medicaid expansion, declaring this optional at the state level. And so you can see that some states chose to expand and some states chose not to. So in those states where they didn't expand, then the very low income people still have an access problem. Now, the subsidies for the low-income individuals are available only through the health insurance exchanges. So to get the subsidy, you can't go directly to an insurance company and buy a plan. You have to go through the health insurance exchange for that mechanism to work. But if your income is under 400% of the federal poverty limit and you're not eligible for Medicaid, then you are eligible for a subsidy for purchasing your own insurance. You also have to be working for an employer who doesn't offer coverage, or it's got to be really lean coverage. It's got to be have copays high enough that the coverage is worse than the bronze level in the exchange, or they've got your share of the premium has to be more than 9.5% of your income. The subsidy brings the individual's share of the premium down to a certain level if they pick the second lowest silver plan. So they don't want to make them pick the cheapest possible silver plan, because that could be just a carrier who wasn't providing really good offerings. And so they pick the second lowest as their benchmark just to protect against the employers that are really undercutting the market. So they pick the second lowest silver plan, and that's the benchmark premium. And the subsidy brings the individual's share of that premium down to 2% if they're in the lowest income bracket, or phasing up to 9.5% for those who are between 300 and 400% of the federal poverty limit. Cost sharing subsidies are also available, as well as the premium subsidies. It depends on where you are in the 100 to 400% federal poverty limit range. For the highest end of that, or the lowest end of that income, the cost sharing subsidies will reduce your cost sharing so you're not paying more than 5% of the cost of coverage on average. So there's some significant deductible and coinsurance subsidies. One of the things that could hit you on these exchanges is that if you underestimate your income when you're enrolling, you may actually have to pay back the subsidies when you do your income tax. So if you think when you're doing your open enrollment in, say, November of 2016 for the 2017 coverage, and you think your income is going to be 200% of the federal poverty limit, and you enroll in coverage and it turns out to be 250 or 300% of the federal poverty limit, you may be getting a subsidy over the course of the year that's more generous than you really are supposed to get under the law. And so when you do your income tax, you would have to pay back some of that subsidy. And I'm not sure that all people understand that. So there may be some real surprises at tax time. So hopefully people are getting counseled to be optimistic in what they think their income is. They need to access those subsidies, but not take advantage of too high a subsidy and get hit on their taxes. The opposite thing happens. If you overestimate your income when you're doing your income tax, you will get a refund. So probably because of cash flow issues, it's better to overestimate your income so you take a lower subsidy and then get paid back the true amount you should get when you do your taxes. Right now, we are waiting for the Supreme Court to rule on some litigation, King versus Burwell. You may have seen headlines about the Burwell case. King versus Burwell contends that only state-run exchanges can offer subsidies. So states that chose to implement health insurance exchanges through the exchange mechanism that the federal government set up couldn't offer subsidies. That relies on a letter of the law interpretation of the language in the Affordable Care Act, which talks about the state giving subsidies. So it'll be interesting to see how that rules. There is a small business tax credit if the business has less than 25 employees and the average wage for their employees is under $50,000, then they are a low-wage earner, low-wage small business. And if the employer offers coverage and pays at least half of the premium cost for their employees, under all of those conditions, the employer can get a credit back of up to 50% of the employer contribution. Other taxation changes. We talked about the individual mandate penalty, and that's computed during the income tax filing. If you are a wealthy person over $85,000, there are higher Medicaid payroll taxes now. So before, I think it's 1.65% that we pay of our income that goes into the Medicare financing. But if you make more than 85%, that payroll tax ratchets up above 1.65% into the 2% range. There is also and also high earners pay Medicare tax on unearned or investment income. So it's not just a payroll tax for high earners, but high earners also have to pay that 1 point whatever percent on their investment income as well as on their earned income. You may have heard a lot lately about the Cadillac tax that's been in the news. So if you're watching some of this kind of policy news lately, you may have been hearing about that. What the Cadillac tax is putting a cap on the income tax exemption for benefits delivered, or income delivered through benefits as opposed to through wages. So if we are delivering compensation through benefits and you have very, very rich benefits, very low co-payments, then you've shifted a lot of your income into this tax-free mechanism. This tax incentive actually, ironically, incents people to provide too much coverage, in the opinion of some economists. What the Cadillac tax does is puts a cap on the value of employer-sponsored insurance that is tax-free. And anything above that gets taxed, and that's called the Cadillac tax. And that's been a frequent subject of debate. People with rich benefit packages are upset about that, and so you've heard a lot of discussion about whether that portion of the ACA should be repealed. And finally, another tax implication is a tax on the sales of medical devices. That is something that's been in the news a lot, that we hear about locally because we have such a vibrant medical device industry here in Minnesota. And in fact, Senator Klobuchar was one of the individuals that negotiated a 2-year moratorium on that tax that went into effect December 15th. And so for the next 2 years, that tax will not be collected. Again, that was a financing mechanism. One of the drivers of trend is increased technology, and so the philosophy was, let's make that increased technology cost a little bit more through the taxes, and then we'll use that to finance subsidies. So with a moratorium on medical device taxes, they got to find another mechanism for financing the subsidies. The establishment of the health insurance exchanges themselves was a big part of the Affordable Care Act. There are two kinds of exchanges. One is the Small Business Health Options Program, or the SHOP program. We don't hear a lot about that because it's kind of a narrow market, just the small business folks, but it is a mechanism that helps small employers find coverages. The implementation of SHOP was delayed for a little bit, took a while to get that off the ground and running. That's also the mechanism through which the small businesses get that tax credit we talked about a couple slides back. Just like we as individuals, if we're going to access our subsidies, have to do it through the individual health insurance exchanges, small employers have to go through the SHOP program to get the small business tax credit. Inside the individual health insurance exchanges, there are 4 categories of plans, and I've been talking about metal levels. Let's finally define them. I think this is the first time in the class we've really talked about what I mean. Bronze plans are plans that pay, the plan itself pays on average 60 to 69% of claims, so that you as the individual, through your deductible, coinsurance, copays, pay on average 30 to 40% of the claims. Silver is a step up. Plan pays 70 to 79. You as the individual pay 20 to 30. Gold is richer. Plan pays 80 to 89. You pay 10 to 20%. And platinum is the richest, where the plan pays 90% or more, very low copayments, and you as the individual pay on average only 10% of claims. If you are under 30 or you're exempt from the mandate, you can access catastrophic coverage. And those are coverages with really high deductibles, like the ones we saw associated with health savings accounts. So, in the $3,000 range. That's there to just give you protection on the outside. So if you got hit by a bus and had really big medical bills, that would kick in and help you out. Underwriting reforms is a very important piece of solving the access problem through the Affordable Care Act. This underwriting of reform applies for purchases in and outside of the exchanges. So whether I go directly to the insurer or I go through the exchange, the underwriting reforms are in place. As long as I am enrolling during the open enrollment period, or if I have an eligible status change, like I have a new baby and I am making a change in my coverage because of that. During these times, I can enroll with guaranteed issue, guaranteed renewability. So guaranteed issue means when I first get covered, they have to give me a plan. Guaranteed renewability means if I'm covered in year 1, they have to continue covering me in year 2. No pre-existing condition restrictions. So if I am pregnant when I enroll, that pregnancy is going to be covered as soon as I'm covered under the plan. No waiting period for coverage. As soon as I enroll, then at the beginning of the benefit plan year, my coverage starts. So if I'm enrolling in November for the 2017 year, my coverage starts January 1, 2017. The premium can vary only by age, geography, family size, and smoking status. And they've put some limits on how big that variation can be. The difference between the average cost of a 65-year-old versus a 25-year-old is pretty big. It's usually somewhere in the neighborhood of 7 times the cost of the young person. But under this underwriting reform, that premium slope can't be any larger than 3. So the highest costing age can't be more than 3 times the lowest costing age. Likewise, for smoking status, smokers can't cost more than 1.5 times non-smokers. Other access changes I referenced the other day in lecture, the essential benefits package. It determines the minimum standards for the types of care that are covered. Also eliminated annual and lifetime maximum payments, so that used to be that they'd pay up to $1 million. Well, if you had a catastrophic accident that took a lot of ICU time and a long rehab, you could easily exceed $1 million in your lifetime. And so these annual and lifetime maximums are now eliminated. It's unlimited coverage. Minimum loss ratios, we talked about that in lecture when I defined what a loss ratio is. Remember, loss ratios are the claims paid out divided by the total premium. And so the bigger the administrative fees, the smaller the loss ratio, because you take claims plus a bigger padding for admin, so you're dividing by a bigger number and it makes the loss ratio go down. So by requiring minimum loss ratios, you're saying a higher percentage of the premium has to be actually used to pay claims, and the admin and profit loads have to be minimized. So for small groups, that minimum is 80%. For large groups, it's 85%. And finally, this one affected us personally because I have a 23-year-old that didn't yet have eligibility to get coverage, and now I can continue to cover him as a dependent on my plan, even during the years when he wasn't in college, took some time off from college. It used to be typically you had to be under 18 or under 22 and in college. And now it's under 26 regardless of your educational status. So parents can help their kids transition into their own plans a little more easily. Now, I talked about the fact that the Affordable Care Act focused really on reforming access to insurance. I just wanted to mention there are some things that are in the Affordable Care Act that address quality and efficiency reforms. In particular, they eliminated that donut hole in the Part D plans. Remember when we talked about it, there was that gap in phase 3 of the Part D plans, and it's starting to be eliminated. It used to be that folks paid all of the cost of pharmacy benefits in the donut hole, and you saw in our description of the current Medicare cost sharing that that's starting to be filled in, and it will eventually get completely filled in. There was funding for something called the PCORI, or Patient-Centered Outcomes Research Institute, and that is a grant-making agency that gives money for research to figure out the best pathway to good outcomes, and given the treatment plans and looking at the treatment pathways, which ones work better for which kinds of patients, and so that kind of research is funded through PCORI. And that's funded through a tax on insurance premiums. The Affordable Care Act creates pilot experiments of new provider reimbursement methods that the bundled payment and the shared savings that we've talked about over and over again are two examples. There was improved coordination between Medicare and Medicaid. So if you are a very low income elderly, you're actually what's called a dual eligible. You're eligible for both Medicare and Medicaid when you're over 65. And so Medicare with those large cost sharing, remember that unlimited 20% cost sharing under Part B. Obviously, low income people can't pay that, and Medicaid fills in those copays for the low income elderly, but sometimes the coordination was a little rocky between the two sides of the Centers for Medicare and Medicaid Services, and so some administrative reforms happened that made that coordination better. Finally, they're experimenting with healthcare homes, and so clinics location can get designated as a healthcare home. They have to go through a certification process to show that they have good electronic health records, that they are doing good team-based care and generally meeting minimum standards. And if they are registered as a healthcare home, Medicaid enrollees with chronic conditions can designate that location as their own healthcare home, and then that healthcare home will receive per capita payments every month for the people that are registered to them, so that they can use those fixed payments to help coordinate care. In practice, it's not happening very well. The people I've talked to have said the administrative burden of billing for those per capita payments is so high that the payment itself doesn't actually even cover the administrative services. So that was something that was a good intention, but didn't quite pan out. And that's the end of the overview of the Affordable Care Act.